Good morning. I'm Muriel Bowser. I'm the mayor of Washington, D.C., and I am here today to provide the district's update on our response to COVID-19. I will provide a few general updates as well as talk about our planning for when the time comes to reopen D.C. We report daily on cases in the district, and this morning we reported 155 new cases of COVID-19, bringing our total to 3,361 positive cases, and we report that a total of 139 Washingtonians have succumbed to the disease. Last week, we know that the White House released guidance around what it takes for cities and states to reopen, and we have looked at this guidance and, as I have stated previously, believe that it is a good framework and in line with what we are looking at locally. And so today I want to share some information with residents and businesses about the criteria we are considering when to reopen and what we're doing to plan for that. Dr. Nesbitt has discussed previously that our thinking is in line with the White House guidance, but there are a few things we need to see before lifting restrictions. And first, that is to observe a consistent downward trend of new cases over a 2-week period. Also, that our healthcare system must be able to treat everyone who needs care without the use of crisis standards of care. In other words, we need to make sure that we're able to provide appropriate care for everyone who needs it. We all know that our community has made too many sacrifices to move forward too quickly or in a way that doesn't prioritize the health and safety of our residents. So we will be deliberate and strategic in our plans to reopen. In addition to meeting this gating criteria, we also know that any effective response and reopening will require widespread contact tracing abilities in order to control and contain the virus. So we need to know who has it and who has been exposed to it. Today, DC Health has a team of about 65 contact tracers, and we are in the process of building that team to over 200 contact tracers. And in the coming week, DOH will make public how we intend to hire for those positions, and we will be advertising for hiring for those positions. But we know that based on our current projections, in order to move safely through phase 1 of the reopening plans, we will need a team of about 900 contact tracers, and plans for how to build that team are underway. Contact tracing alone, however, won't be enough, and we also know that having widespread and accessible testing will be needed. Yesterday, I shared a few ways we're expanding testing. A new public testing site is open today. I had the opportunity to drive through this morning at UDC at Bertie Bacchus, which is just across from the Fort Totten Metro. Testing of some asymptomatic individuals and the use of rapid point-of-care instruments in some of our congregate settings is expanding our testing capacity in the district. DC Health has also looked at the collective testing capacity of sites across the city. And right now, combined with public and private testing, we have enough platforms to run 3,700 tests per day. And just yesterday, we learned that our public health lab will receive a new instrument that will double our capacity. So we're pleased to share that news. So now that work continues, we want to make sure that we're able to take full advantage of that capacity And that means continuing to call on the federal government to support cities and states with procuring all of the resources that we need to conduct massive and widespread testing. So having discussed our work on contact tracing and testing, we want to talk about how we're thinking about our reopening strategies. Of course, one of the very distressing aspects of this pandemic has been the racial inequities and how they play out right in front of our eyes with the data I report each day. And it's not just distressing, it's also very scary to a lot of people and a lot of families in Washington, D.C. And I've said several times that when we get on the other side of this, what that means in D.C. and across the nation is that we have to do better and we have to tackle the long-standing inequities that are causing these disparities. Disparities that didn't just appear during this pandemic, not last year or the year before that, but for decades and indeed centuries. And so as we think about reopening, we also see this as an opportunity, not just to go back to the way things were before, but to do and be better than before. So we're going to have to do better with limited resources, but we have a once-in-a-generation opportunity to reopen our city in a way that builds a more equitable D.C. And we should not let this opportunity pass us by. It's also important to me that our plans to reopen the city are community-driven and informed by community voices. And so just as the government cannot solve this pandemic alone, we cannot reopen alone. We all need to be working together to make sure that we're listening to our health experts, but we're also listening to the needs of our businesses and residents. So together we need to create a plan that is based on science and tailored to what the Washington, D.C. community needs. So right now I am putting together a Reopen D.C. advisory group comprised of government and community leaders. This advisory group will have 12 committees that will guide when and how we reopen, as well as how we monitor our progress. There will be a committee of co-chairs, a committee focused on equity, disparity reduction in vulnerable populations. Public health innovation and workforce is another committee. Transportation and infrastructure, as well as open spaces and recreation, will form 2 committees. Education and child care will be a focus. Government ops, public safety, and criminal justice will be another focus area. Faith, arts, culture, hotels, and entertainment will be a focus area. Restaurants and food retailers will be a subcommittee. Retail and small business, a committee. Human services, social services, and health, and finally real estate and construction. The advisory group will be advised by the Johns Hopkins Bloomberg School of Public Health, and the work of the 12 committees will be guided by the public health principles for a phased reopening during COVID-19 guidance for governors, also published by Johns Hopkins School of Health. And here you can see that we are focused on 4 guiding values and priorities for the Reopen DC group. First, we're going to be focused on health. Obviously, this pandemic has exposed wide health disparities. So this means that we will be thinking about how we improve health outcomes, especially for African Americans and our vulnerable populations. It means helping our small business owners get back on their feet. It also means how we create new job opportunities and new opportunities for our students. Many people have been affected in different ways by this pandemic, physically, emotionally, and financially. And no matter how someone has been affected, we will attempt to address their needs. We want to provide, of course, a sense of hope about what's on the other side of this. Clearly, you've heard me say before this pandemic, we were a growing, thriving city that was very secure financially and investing in the inequities we saw in the city. And we'll be that city again, but stronger and even more focused on all of the things all of the areas for improvement in curing inequities in our city. Of course, in many ways, these priorities and values are not new. In fact, we recognize these priorities, health, opportunity, prosperity, and equity, from the final draft of the comprehensive plan that we released last fall. And today, we are sending the updated comp plan to the DC Council. The comp plan will help guide us through as we recover in a way that works for current residents and future generations of Washingtonians. So I know Washingtonians, like I am, are eager to get on the other side of this, and we have to keep working together to flatten the curve. I just commented to my team before we came in here, as I was coming here, it seemed like I saw more people moving around, more people driving, more people going from place to place. And I want to remind everybody very clearly that we are in a stay-at-home posture in Washington, D.C. until at least May 15th. You should only be going out for essential work, exercise, food, or medicine. And then you should be going back home. And staying home. So I just want to remind everybody that our orders to wear masks on those essential trips is not a replacement for staying at home. So let us, while we know that things could be worse in the district, we want to save as many lives as possible. And we do that by staying home. So with that, we have time for a few questions today. We do have a hard stop, and so I'll start with Sam.
Mayor, so do you see this happening all at once, or do you see this gradually in stages? I mean,
do I see what happening?
The reopening of the city. I know you have a list of groups, but do you think the city is going to sort of reopen like that, or is it going to be like in various?
Well, I referred to phases of opening that have been widely discussed. I've also talked about how we still have to get to phase one, and we can go back to the slide that talks about several of the criteria that are needed to get there. And if your question is, do I think every business will open on the same day? While I don't want to get ahead of the work of our medical team or the team that's going to be looking at this in detail, I don't think that we're going to have a light switch and everything goes back as normal.
Do you have any prediction as to when this might start to happen?
That's my prediction. When we observe a consistent downward trend in cases, when our hospital capacity can operate in a normal fashion, and when we are very confident, which we are gaining confidence in testing and tracing capacities in the district.
June, July, August.
Okay. Next question. Yes.
I'm looking at your, today DC Health has about 65 contract tracers and about 70% of confirmed cases have been traced. Can Dr. Nesbitt or even Dr. Smith give us some kind of an analysis as to what are the contract tracers finding? Are we seeing hotspots? Like, are these around these long-term health facilities? Are these people from around the jail, from St. Eves, or in certain neighborhoods?
Let me turn to Dr. Nesbitt.
Sure. Thank you so much for the question. What we have been focused on with our contact tracing at this point is our high priority populations, and which are the ones that you've outlined. So our congregate settings, our high-risk populations, especially those who are seniors and some individuals with chronic health conditions. And we are beginning to see some of the cases cluster around our long-term care facilities and our immediate care facilities and our congregate settings, including some of our homeless shelters. We have decided to focus on those populations because of the risk of transmission in those types of settings. And while we are in mitigation, remember, we talked a lot about being in containment, in mitigation, and then transitioning into containment again. It is not necessarily of great benefit to contact trace every single case because it's difficult to identify the source of exposure for those of us who are moving around in the community, who it would be impractical to say that our exposure or the reason for our coronavirus or COVID-19 is because we were with X person or in X venue, because we have such widespread community transmission. For individuals who are in congregate environments or who are in long-term care facilities or who are in healthcare settings, we prioritize contact tracing those individuals because we can cohort them, which means to move them into certain environments where they don't spread to people who are currently negative. And that's why we focus on those populations. The reason why we want to increase the number of contact tracers when we move into containment again, or as we move into phase 1, which is imagining a reopening of certain aspects of our city, is because as people begin to move around, they're going to have more social contacts. And as they have more social contacts, we're going to need to touch more people. Based on our experience, when we were in containment before, each individual produces approximately 8 contacts that will need to be interviewed in depth. And so that's the kind of work that a contact tracer does. You'll see there, once a person is tested as COVID positive, we have to identify who they are. We isolate them immediately, which means to take a sick person, a person who is diagnosed with the infection, remove them from their environment, put them in an environment where they are not in contact with any other person. We then trace them, which is an in-depth interview that asks all of the things that they've done for the 14-day for the period preceding their time when they're suspected to be infectious, which we now know can be 2 days prior to when they were showing signs and symptoms of infection. That's the trace. And then all of the people who they came into close contact with will be asked to quarantine. That's the quarantine piece. And then we connect them to all of the support services that they may need while they are separated. So not just the person in isolation, but all of the people who are then being quarantined.
When you say congregate settings, what do you mean?
So congregate settings are group environments where a lot of people live. So you don't tend to think about apartment buildings and condominiums as congregate settings because people have private dwellings. While there may be shared space like community rooms and gyms and pools in those buildings, everybody tends to have a private dwelling with their own bedroom, their own bathroom. Congregate settings are more like low barrier shelters or emergency shelters, long-term care facilities where individuals may share bedrooms or receive intimate services like nursing services from staff who are providing services to multiple people. Detention centers are congregate settings. Though hospitals tend to be congregate settings. Anytime people are sharing, bathrooms, dining halls, things of that nature.
Dr. Nesbitt, so we want to see 2 weeks of declining new infections. How do we see that when we're also increasing testing that can return more positive results?
Oh, it's a perfect question. An astute observation. So we can test more people and still see a downward trend in new cases. Because if the number of interactions that people are having is diminished, you can still have people who are presenting that are only symptomatic or who may be asymptomatic with an exposure that was not a high contact exposure, who may be presenting for testing but are still negative. So that positivity rate that we've talked about before can be on the decline. and not necessarily trigger a number of new cases. So that's one of the reasons why we've also been very interested in having people decrease the threshold for who is being tested, so that we can expand the denominator of people being tested. It's important to note, I know there's some publications out there, one that we've even looked at, that has made a recommendation for the total number of people who should be tested in order for governments to be open, et cetera. That applies a uniform number for the country and then divides it amongst the population. You should note that the presence of disease is not the same across the country, so it makes it very difficult to apply that metric. But even if you were to do that, the number that's used in that study is not our current number of tests that's happening in the district. We're more, if you just look at district residents, we're more around 400 people tests a day. If you look at the total number of tests that are given in the district, it's almost close to 600 on average every day, from early March until now. And so even with that, we have a positivity rate at around 20%. We want to have that positivity rate go down to around 10% to be able to have a good indicator of where we are. But again, it's more important to focus on the target populations, the people who are more at risk for infection, who've had an exposure to infection when you're using diagnostic tests that test for current infection.
I think I understand that. So the point is that even if we're seeing the number of overall infections going up, if we're having drastically new testing and you have a smaller share of people being tested, testing positive, that shows we're in a good.
You can look for proportionality, right? Mm-hmm. So that's the thing to be looking for, proportionality. So it's like you can continue to look at that positive rate of positivity. So if the denominator and the numerator get bigger at the same time, your rate of positivity still being the same. Should stay the same, right? Now, if we have more people getting tested, but not as many of them being positive, then our rate of positivity will go down.
Mayor Bowser, can you expand on what you meant when you said we have a once-in-a-generation opportunity to reopen our city in a way that builds a more equitable DC?
Yes, I think that we are going to look across all of the different committees that I mentioned, but also the guiding principles that I talked about, health, how we have more equitable health outcomes, more opportunities for individuals and families, looking at the prosperity of our city, how we get it back and how we make it more equitable. But also looking at some of the real inequities in jobs, in housing, in education that have also been exposed. Yes?
Could you talk a little bit about, it sounds like you're going to be hiring more than 800 people to do the contact tracing force. Can you tell us who those people, who you're looking for, and where they might come from, and if somebody wants to apply?
We haven't made a job announcement, and we will. I think we're talking about directly hiring up to 200 from the Department of Health. And then Dr. Nesbitt and her team are working on a strategy to get to the other 700. So you want to say a little bit more about?
Sure. So this will be individuals with a wide range of skill sets. But some of the positions will be entry level. So if you're familiar with the concept of community health workers, who are people who are peers, who are individuals from the community who have the ability to be able to conduct some of these interviews, we can provide just-in-time training to help them understand what the script looks like when we're conducting the interviews. Then we'll have some people who have more public health background, public health skills. There are bachelor's degrees in public health, there are master's degrees in public health, and so we'll be looking for people who have that type of skill set. Those will be individuals who are looking to be hired by the Department of Health, or individuals who are currently students at the undergraduate level, graduate level from some of our schools and programs of public health in the district and across the region, who have been in contact with us about working very closely with us. So that's another source to expand our workforce. And then we have the opportunity to do more recruitment, as we have had over 6,000 people from the Medical Reserve Corps who are not clinicians can add to this workforce as well. So as the number of individuals that we hire increases, some of the positions will be frontline entry level, some of the positions will be at the supervisory level, and then we will deploy them accordingly. Many of them will be conducting the interviews. Some of them will be doing outreach and inreach into communities to have them socialize to what the process is, the importance of being responsive to the government when we're asking these questions, because it's the best way to reduce transmission. And then some of them will have roles around ensuring the adequacy and accuracy of the data entry and making sure that we are having successful attempts at reaching people. So we will outreach to people who have been a contact or who are a case using a number of methods. Direct phone calls, mails, emails. We may have to actually do some home visits, and we're definitely going to have an overlay of technology with some of this.
Mayor Bowser, do you have a timeline on your committees to reopen the task force that you're putting together? Have you named anybody or talked to anybody about being those co-chairs?
Sure, we're working very hard right now, Mark, to populate all of our committees. Their time frame will be short, and we will be able to have a schedule and other engagement opportunities posted shortly. And we're going to ask them to turn around some recommendations to us in May.
And then could I ask about, I asked this the other day of the doctors, and I'm wondering again about the distribution of ventilators. Can you be any more specific about, we see the numbers every day that we appreciate how many ventilators there are and how many are available, but we don't know the distribution of those. Can you provide that data? Is that something that you can get?
So I don't have with me the actual number of ventilators in each hospital, because I think that's what you're asking me, like how many ventilators are in Washington Hospital Center, how many ventilators are in Georgetown, how many are in Sibley. We can get you that number, but I think the more important point is that we have requested ventilators, we have purchased ventilators, and that any hospital who is using all of their ventilators has access to ventilators from the district. So we have not, across the city, we are not using all of the ventilators that are currently in hospitals. So no hospital has indicated to us that they are using all of their ventilators. And our current hospital information system does not indicate that we've had to divert patients from one place to the other because no ventilators were available at one place for another patient, or a hospital has not requested to us that they receive additional ventilators. But we'd be more than happy to provide you how many ventilators each hospital has. But I will tell you that it correlates to their bed numbers and to their trauma level, et cetera.
Okay, Sam?
I want to ask about the jail again. Of course, there was the ruling the other day, but I got a letter overnight saying basically that this is still a problem of inmates getting showers. In fact, last night, you had 2 inmates who refused to cooperate to the point they were pepper sprayed. They eventually got a shower after that. But in some cases, inmates are still in the cell up to 4 days without a shower.
I expect to get a report from my team tomorrow. Today's Thursday, on Friday. I can't comment on any individual incident that I don't have any history of. I just can't comment on that. I'm sorry?
Give us some information tomorrow.
Well, if you tell me, if you share that letter with us, we probably can give you some information later today. Okay, thank you. Yes?
Can you update us on what the district is doing to get personal protective equipment? I mean, Maryland, there was a person from South Korea that got a lot of attention. Is there something similar in the works in D.C.?
We presented that information a couple days ago. We can give you our latest on PPE. Yes.
Dr. Smith, the asymptomatic testing in the city, have you been able to maybe have you seen perhaps overnight or into today where the number of prescriptions may have gone up, and or the other question I had about that is asymptomatic testing being done at all of the 10 sites in the city, including the public sites and the private sites?
Well, I think we're still yet to see what's going to happen as the new drive-in facility and as some of these other facilities open up, to include the ability to walk up and be tested as this new guidance has gone out. So the guidance applies across all of the facilities that we are supporting.
But at this moment, you can't say that you've seen an increase in appointments and or prescriptions from doctors for asymptomatic people.
That's correct, because literally it was announced yesterday. And as I said, I believe the new drive-up facility is starting today. So
It started today,
We
yes.
will be excited to see the number of people that show up there and be able to provide them testing.
Yes.
About the letter that you and the governors just sent to the president, I know you mentioned before you want to extend telework for federal employees. Can you tell us if you've got any feedback from the White House or the federal government about extending that, or when they might try to roll that back, and what are your concerns?
Well, we just want to, we don't have a concern right now because that letter that we sent is consistent with the guidelines that came from the White House. So we just want to make it very clear that in order for this region to be able to progress through the phases, we think that the telework policy for the National Capital Region should remain in place.
Do you know how long you would like it to remain in place?
Until we go through the phases. We can refer you to the phases, phase 1, and I think they even recommended to phase 2. More telework. That doesn't mean it's in the exact same posture that they're in, but as many people as possible working from home. Keep in mind that government work is essential work, and just like we have done here, some people can do it in place and some people can do it by teleworking. But the local governments, the federal governments have to be able to function, and they are essential jobs, and the same is true for the feds. Yes, and did you have a last question?
Yeah, I mean, DC hasn't seen the kind of Michigan, Pennsylvania protests against these stay-at-home orders, but how are you factoring in like potential defiance and people getting fed up with all these restrictions as you're planning?
Let me understand your question again.
Basically, how are you considering potential defiance and potential flouting of all these restrictions when you're planning for how this virus spreads across the city?
Well, I think that DC residents and businesses, and let me, and I talk a lot about the sacrifices people are making, and we recognize that before our response to this pandemic began, that people had bustling businesses and 70,000 people had jobs that don't have them right now, or they now have lower wages. So this response is significant, but so is the challenge before us, the health challenge. And we have seen, unfortunately, with our fellow Americans in New York, what happens when the medical system is bombarded with very, very sick people. So what we are doing, we know will save lives because it will allow our medical system to be able to respond to this pandemic. And that's why it's so important. But people should also know that we want to get open. I don't know anybody up here that works for us that doesn't want our kids to be able to go to school, people to be able to go out to the restaurants and theaters and sports and entertainment, all of the things that make our city so wonderful. So everybody wants to get open, but we also don't want to lose the gains that we have made, and we want to do it in a way that is sustainable. We have all heard, while it's in dispute, everybody knows that we have to be prepared for a fall, winter season of flu and possibly corona. I think that we can learn some things from turning on our economy in a systematic way. We can learn if we have to dial it back if we have another outbreak. So I am looking forward to even more expert voices informing our discussion about how to turn on our economy. But I have to say that DC residents have been very supportive of doing what it takes to save lives in our city, and also supportive of our approach to taking in information from our medical and science folks, but also everybody who is on the ground with businesses and lost jobs.
We're also seeing more voices nationally that are saying, you know what, it's okay to sacrifice lives, hundreds of thousands of lives, in saving the economy. What do you think when you hear this kind of rhetoric?
I don't agree with that. I mean, it's shocking in some ways. This is you know what I would say to folks who say, you know, those people are old, they're going to die anyway, and that's just not the America that I believe in. I believe in a country like ours, that we should be able to do the testing, do the isolating, produce the materials, all of the things that it takes to respond to a pandemic such as this. We have what it takes to respond, and we have to not only live up to our values, but to the ingenuity and spirit of America in responding to this crisis. So we are going to do everything that we can to save vulnerable populations in Washington, D.C., and we're going to do everything that we can to make sure that those folks aren't as vulnerable if we are hit with another crisis like this or some other crisis. Okay. All right. I have one question on the phone. Tom?
Yes, thank you, Mayor. Thank you for taking our calls. The Board of Elections today said it's having some problems with email requests for absentee ballots. Are you confident that the board has the staff and the technology to do a massive mail-in election? And when will there be a sustained public service announcement campaign to educate voters on the complicated three-step process where you have to ask for a ballot, get the ballot, and return the ballot for the June primary?
Well, I wasn't aware that it was complicated, or I haven't been made aware of any problems with their email. The board, of course, Tom, as you know, is an independent board, and I have invited them here a couple of times to make clear their plans. I have also assigned a couple of members of my cabinet to work with them on space and volunteers. And we will offer them other cabinet assistance to make sure that they have what they need.
Thank you.
All right, thank you, everybody.